Upper extremity nerve pathologies and differential diagnosis. Here's a picture of the median nerve in the upper extremity. Major entrapment areas are the carpal tunnel, pronator teres, and between the pronator teres and proximal edge of the FDS. The median nerve lesion typically presents as a sensory deficit in the volar, thumb, index, long, and radial half of the ring finger. If the lesion is proximal, you can expect weakness in the muscles listed, which are muscles in the forearm and hand that are innervated by the median nerve. If the lesion is distal, the forearm and wrist flexors will be spared. You will see weakness in the opponens pollicis and flexor pollicis brevis. With distal median nerve lesions, you will typically see the ape hand deformity. This is the ape hand deformity that you will see with a distal median nerve lesion due to loss of opposition. Now we will discuss some pathologies that you will see as a result of median nerve compression. Pronator syndrome occurs when the median nerve is compressed between the two heads of the pronator and the arch of the FDS. This typically presents as anterior elbow and forearm pain. Some sources report weakness of the thumb, index, and middle fingers due to involvement of the FPL, FDP, and FDS. Sensory changes will occur on the palmar surface of digits 1 to 3 and half of 4. These patients often report feeling achiness or a dead feeling in the arm. The top differential diagnoses for pronator syndrome are cervical spine referral, medial epicondylitis, and anterior interosseous nerve syndrome. We also learned in lecture that lateral epicondylitis could be a differential diagnosis. On these lists, I chose the tests with the best sensitivities, specificities according to the literature. To rule out pronator syndrome, a positive passive positioning test would be indicative of medial epicondylitis. A positive Mills, Cosen's, or third finger extension test would be indicative of lateral epicondylitis. Changes in DTR and/or positive Sperling's or distraction would be more indicative of cervical spine referral. And a positive OK sign would be more indicative of anterior interosseous nerve syndrome. To rule in pronator syndrome, typically you would see pain or reproduction of symptoms with resisted elbow flexion pronation manual muscle testing or activation of the pronator, a positive ULTT median, a positive Tunnell sign at the pronator teres, and a negative OK sign. Anterior interosseous nerve syndrome occurs when the median nerve is compressed at the pronator teres and proximal edge of the FDS. You will typically see weakness in the FPL and FDP of the index finger. These patients will report no changes in sensation, but weakness in activities involving thumb flexion and second digit flexion. Therefore, they will be unable to make the OK sign. The top differential diagnoses for anterior interosseous nerve syndrome are cervical spine referral and pronator syndrome. To rule out anterior interosseous nerve syndrome, a positive ULTT median will be more indicative of either cervical spine referral or pronator syndrome. Changes in DTR and/or positive Sperling's or distraction would be more indicative of cervical spine referral. Positive Tunnells at the pronator teres will be more indicative of pronator syndrome. To rule in anterior interosseous nerve syndrome, you will see weakness with resisted thumb flexion and second digit flexion. You will see a positive OK sign. And an EMG can confirm anterior interosseous nerve syndrome in 80 to 90% of cases. Carpal tunnel syndrome is very common and presents as numbness and tingling in the palm and into the thumb, index, middle, and half of fourth finger. Numbness at night is often reported, and clumsiness or a change in handwriting due to difficulty with fine motor skills. The top differential diagnoses for carpal tunnel syndrome are listed. To rule out carpal tunnel syndrome, the first two bullets are more indicative of cervical spine referral. Positive OK sign is more indicative of anterior interosseous nerve syndrome. Positive Tunnells at the pronator teres or pain and reproduction of symptoms with resisted pronator teres contraction is more indicative of pronator syndrome. To rule in carpal tunnel syndrome, typically you will see atrophy of the thenar musculature, and you may even see the ape hand deformity that we previously discussed if it is long-standing. You will see weakness of resisted thumb abduction and positive Tunnell sign at the carpal tunnel. The ulnar nerve can become entrapped within the cubital tunnel, in the medial intermuscular septum due to the arcade of Struthers, near the medial epicondyle at the entrance to the cubital tunnel, and under the fascia of the FCU or between the two heads. A proximal ulnar nerve lesion can present as sensory loss in the small and ulnar half of the ring fingers and ulnar aspect of the hand, both dorsal and volar. In addition, you will see weakness in the FCU, FDP to the ring and small fingers, hypophenar musculature, interossei, third and fourth lumbricals, adductor pollicis, and deep head of the FPB. A distal ulnar nerve lesion will typically spare sensation on the dorsal ulnar aspect of the hand due to branching of the dorsal branch of the ulnar nerve in the forearm. If the lesion is proximal to the ulnar tunnel, they will lose sensation in the volar ulnar aspect of the hand and have weakness in the hand, excluding wrist flexion ulnar deviation and fourth and fifth digit flexion due to sparing of the FCU and FDP to those digits. If the lesion is distal to the bifurcation of the ulnar nerve into deep and superficial and it is a deep branch injury, they will present with weakness in the hypophenar musculature and hand intrinsics, but have normal sensation. If the lesion to the deep branch is distal to the abductor digiti minimi branch, they will have weakness in their interossei but spared hypophenar musculature. If the lesion involves the superficial branch of the ulnar nerve, they will lose sensation on the volar ulnar aspect of the hand and have weakness in the palmaris brevis, which is hard to appreciate but helps to fold the skin. If patients have motor loss in intrinsics of the hand due to an ulnar nerve lesion, they are at risk of developing claw hand. Cubital tunnel syndrome typically presents as pain, paresthesias, weakness in the ulnar side of the fourth and fifth digit. They report difficulty sleeping, snapping or popping, clumsiness or lack of coordination, and weakness with gripping. The main differential diagnoses for cubital tunnel syndrome are listed. To rule out cubital tunnel syndrome, you would typically see a negative pressure provocative test. So this is a test where the elbow is held in flexion and pressure is applied to the ulnar nerve for 30 seconds in the medial epicondyle. A positive would be reproduction and pain. You will also see a negative elbow flexion test. This test is performed bilaterally. The shoulders are in external rotation and the elbows are in full flexion with wrist extension for 1 minute. A positive would be pain near the medial epicondyle and numbness tingling in the ulnar distribution. You'll see a negative Tenals at the cubital tunnel to rule out cubital tunnel syndrome and a negative ULTT ulnar. You will see no weakness in any muscles innervated by the ulnar nerve. The last two bullets will be more indicative of cervical spine referral. Positive tests for thoracic outlet syndrome and or suspicion of a Pancoast tumor would also rule out cubital tunnel syndrome. A Pancoast tumor is typically found in men greater than 50 with a history of smoking, and they often present with medial scapular border pain, but they can also have burning in the ulnar nerve distribution. To rule in cubital tunnel syndrome, you will typically see a positive pressure provocative test, flexion test, Tenels at the cubital tunnel, and ULTT ulnar. You will see weakness in the ulnar innervated musculature and weak grip strength. In addition, you will see a positive Wartenberg sign, and this is when the fifth digit drifts out to the side due to a loss of abductor digiti minimi. Guyon's canal is an ulnar nerve entrapment that often occurs in cyclists. It involves pain, numbness, tingling, and or weakness in the fourth and fifth digits of the hand along with decreased grip strength. The top differential diagnoses for Guyon's canal are listed. To rule out Guyon's canal entrapment, you will typically see a positive Tenel sign at the cubital tunnel, a negative Froment sign. This is when you have the patient pinch a piece of paper and the therapist tries to pull the paper out from under their thumb. A positive would be flexion of the IP due to loss of adductor pollicis and would be indicative of ulnar nerve pathology. If they have a positive flexion test at the cubital tunnel or weakness in the FCU, this is more indicative of cubital tunnel syndrome. Change in symptoms with Sperling's or distraction would be more indicative of cervical spine referral, and positive TFCC special tests would be more indicative of a TFCC injury. To rule in Guyon's canal entrapment, you will see a positive Froment sign. You may see clawing of the fourth and fifth digits due to loss of lumbricals and FDP to the fourth and fifth digits. You'll also see decreased grip strength or a key pinch grip similar to Froment, and you may have weakness in the hand intrinsics. The radial nerve can become entrapped within the arcade of Frosch, or the proximal edge of the supinator, between the brachioradialis and the radiocapitellar capsule, at the distal edge of the supinator, under the ECRB, and within the vascular leash of Henry. Proximal radial nerve lesions often occur with humeral fractures or elbow dislocations. With proximal radial nerve lesions, you will often see a wrist drop deformity due to weakness in the wrist and thumb extensors. If the lesion is proximal to the radial head, you will see weakness in the anconeus, brachioradialis, and wrist thumb finger extensors, along with sensory loss in the radial side of the hand, including the dorsal aspect of the thumb, index, and long fingers. Here's a picture of the wrist drop deformity that you will see with a proximal radial nerve lesion. If the lesion is distal to the bifurcation of the radial nerve into the posterior interosseous nerve and superficial sensory branches, you will see isolated motor deficits if it is a lesion to the pin, or isolated sensory deficits if it is a lesion to the superficial sensory branch. Posterior interosseous nerve syndrome presents as motor deficits and weakness with activities involving wrist extension with radial deviation and finger extension. In addition, these patients often report lateral forearm or elbow pain and pain near the lateral epicondyle when extending their thumb. These patients do not present with paresthesias or sensory deficits. The top differential diagnoses for posterior interosseous nerve syndrome are listed. To rule out posterior interosseous nerve syndrome, you will see positive clinical tests for lateral epicondylitis. A positive ULTT radial is more indicative of cervical spine referral or radial tunnel syndrome. Decreased sensation to light touch in the lateral forearm would be more of a musculocutaneous nerve pathology. And the last two bullets are more indicative of cervical spine referral. To rule in posterior interosseous nerve syndrome, you will see weakness when performing the Cosen's test and third finger extension test. In addition, you will see weakness with resisted thumb extension. Radial tunnel syndrome presents as pain in the lateral forearm, especially with activities that involve repetitive wrist flexion and/or pronation. These patients do not typically present with weakness or report sensation deficits. The top differential diagnoses for radial tunnel syndrome include cervical spine referral, lateral epicondylitis, and posterior interosseous syndrome. To rule out radial tunnel syndrome, you will see positive clinical tests for lateral epicondylitis. If they are tender to palpation at the lateral epicondyle rather than at the brachioradialis muscle belly, this would be more indicative of lateral epicondylitis. The last two bullets again would be more indicative of cervical spine referral. To rule in radial tunnel syndrome, you will see tenderness to palpation at the brachioradialis muscle belly. They will also have pain with resisted forearm supination, wrist flexion, or pronation. You will also see a positive ULTT radial. Wartenberg syndrome. These patients may report history of trauma, diabetes, repeated exposure to cold, repetitive use of hands, recent casting, or distal radial ulnar joint dislocation. They often report pain, numbness, tingling, and/or hypersensitivity near the radial aspect of the wrist, dorsal thumb, or radiodorsal aspect of the hand. The top differential diagnoses for Wartenberg syndrome are listed. To rule out Wartenberg syndrome, the first two bullets will be more indicative of cervical spine referral. Weakness in ECRL, ECRB, extensor digitorum, or thumb extension would be more indicative of posterior interosseous nerve syndrome. A positive Finkelstein would be more indicative of de Quervain's tenosynovitis. And a positive first CMC grind test is more indicative of first CMC arthritis. To rule in Wartenberg syndrome, you will see decreased sensation in the areas previously discussed, positive tunnels on the radial aspect of the wrist, and pain is often reproduced with wrist extension and radial deviation when tested in a position of supination. Pain is also reproduced with passive wrist flexion, ulnar deviation, and pronation. In conclusion, always use the history portion of your evaluation to help guide your choices in tests and measures. Choose tests with the highest statistical values to rule out your differential diagnoses, and then rule in your top differential diagnosis. And always treat the primary impairments found on exam. And here are some references.